Let's begin, doctors. Our today's topic, temporomandibular disorders. Contents of our today's lecture. First part, introduction. The most important functions of the temporomandibular joint, TMJ, are mastication and speech, and are of great interest to dentists, orthodontists, clinicians, and radiologists. The TMJ is a gendylomo-arthroidal joint, a term that is derived from gendylomus, meaning a hinge joint, allowing motion only backward and forward in one plane, and arthroida, meaning a joint of which permits a gliding motion of surfaces. The right and left temporomandibular joint form a bicondylar articulation, and the ellipsoid variety of the synovial joint similar to knee articulation. The common features of synovial joints exhibited by this joint include a disc, bone, fibrous capsule, fluid, synovial membrane, and ligaments. However, the features of that differentiate and make the joint unique are its articulate surface covered by fibrocartilage instead of hyaline cartilage. Let's stop at peculiarities of temporomandibular joint. First one, the joint is bilateral diarthrosis. What does it mean? It means that right and left function together. Second one, articular surface covered by fibrocartilage instead of hyaline cartilage. Third peculiarity, only joint in human body to have a rigid end point of closure, that of the teeth making. In contrast to other diarthroidal joints, temporomandibular joint's last joint to start develop in about 7th week in utero. And you know that TMJ develops from two distinct blastema. Anatomy of TMJ. Mandibular condyle. It is an ovoid process seated atop of narrow mandibular neck. It's the articulating surface of the mandible. It is convex in all directions, but wider lateral mesially, 15 to 20 millimeters, then anterior posteriorly, 8 to 10 millimeters. It has lateral and medial poles. The medial pole is directed more posteriorly. Pay attention. Medial pole is directed more posteriorly. Thus, if the long axes of two condyles are extended medially, they meet at approximately the basin on the anterior limit of the foramen magnum, forming an angle that opens toward the front, ranging from 145 to 160 degrees. The articular surface lies on its anterior superior aspect, thus facing the posterior slope of the articular eminence of the temporal bone. There are shown two views, anterior and posterior. A. Anterior, B. Posterior view. A dotted line marks the border of the articular surface. Note that the articular surface on the posterior aspect of the condyle is greater than on the anterior aspect. The articular surface of the temporal bone is situated on the inferior aspect of temporal squama anterior to tympanic plate. Various anatomical terms of the joint are elaborated. And now let's talk about anatomical terms. articular eminence, in Latin eminentia articulare. This is the entire transverse bony bar that forms the anterior root of zygoma. This articular surface is most heavily traveled by the condyle and disc as they reach forward and backward in normal jaw function. Articular tubercle or protuberantio articulare. This is a small raised roof bony knob on the outer end of the articular eminence. It projects below the level of the articular surface and serves to attach the lateral collateral ligament of the joint. Preglenoid plane. This is the slightly hollowed, almost horizontal articular surface continuing anteriorly from the height of the articular eminence. Posterior articular ridge and the postglenoid process. The posterior part of the mandibular fossa is an anterior margin of the petrous squamosous suture and is elevated to form a ridge known as the posterior articular ridge or lip. This ridge increases in height laterally to form a thickness, cone-shaped prominence called the postglenoid process immediately anterior to the external acoustic meatus. Lateral border of the mandibular fossa. This structure is usually raised to form a slight crest joining the articular tubercle in front, with the postglenoid process behind. Medially, the fossa narrows considerably and is bounded by a bony wall, that is the anteglenoid process, which passes slightly medially at the medial glenoid plane.
А в чому проблема? Ну так, ну в пострі. Ну, не знаю, чого вони засилили.
Нормально. Добре, бо воно постійно від'їжджає, я ж стрічку можу підбирати, щоб воно було тягнутися.
The roof of the mandibular fossa, which separates it from the middle cranial fossa, is always thin and translucent, even in the heavy skull. This demonstrates that although the articular fossa contains the posterior rim of the disc and the condyle, it is not a functionally stress-bearing part of the craniomandibular articulation. Next element of temporomandibular joint, it is articular disc. The articular disc is the most important anatomic structure of the TMJ. It is a biconcave fibrocartilaginous structure located between the mandibular condyle and the temporal bone component of the joint. It functions to accommodate a hinging action as well as the gliding actions between the temporal and mandibular articular bone. The articular disc is a roughly oval, firm, fibrous plate. Its anterior band is near 2 mm in thickness, posterior band is 3 mm thick. Thin in the center, intermediate band of 1 mm thickness. It is shaped like a peaked cap that divides the joint into a larger upper compartment and smaller lower compartment. More posteriorly, there is a bilaminar or retrodiscal region. In TMJ, there are present two kinds of movements, hinging movements and gliding movements. And you need to know that hinging movements take place in the lower compartment. and gliding movements take place in the upper compartment. The superior surface of the disc, saddle-shaped to fit into the cranial contour, and the inferior surface, concave to fit against the mandibular condyle. The disc is attached all around the joint capsule, except for the strong straps that fix the disc directly to the medial and lateral condylar poles, which ensure that the disc and condyle move together in protection and retraction. The anterior extension of the disc is attached to a fibrous capsula superiorly and inferiorly. In between it gives insertion to the lateral pterygoid muscle, where the fibrous capsule is lacking and the synovial membrane is supported only by a loose alveolar tissue. The anterior and posterior bands have predominantly transversal running fibers, while the thin intermediate zone has anterior-posteriorly oriented fibers. Posteriorly, the bilaminar region consists of two layers of fibers separated by a loose connective tissue. The upper layer of temporal lamina is composed of elastin and is attached to the postglenoid process, medially extended ridge, which is the true posterior boundary of the joint. It prevents slipping on the disc while yawning. The inferior layer of the fibers of inferior lamina curve down behind the condyle to fuse with the capsule and back of the condylar neck at the lowest limit of the joint space. It prevents excessive rotation of the disc of the condyle. On sagittal MRI, the disc, biconcave structure with homogeneous low signal intensity, that is attached posteriorly to the bilaminar zone, which demonstrates intermediate signal intensity. The anterior band lies immediately in front of the condyle and the junction of the bilaminar zone, and the disc lies at the superior part of the condyle. The posterior band and retrodiscal tissue are best depicted in the open mouth position. Next element, fibrous capsule. The outline of attachment of the mandibular neck. They are present laterally. The lateral condyle pole, but medially, dips below the medial pole. On the lateral part of the joint, the capsule is a well-defined structure that functionally limits the forward translation of the condyle. Lateral pole, medial pole. Medially and laterally connects with the condylodiscal ligaments. This capsule is reinforced more laterally by an external temporomandibular joint ligament, which also limits the destruction and the posterior movement of the condyle. Anteriorly, the capsule has an orifice through which the lateral pterygoid tendon passes. This area of relative weakness in the capsular lining becomes a source of possible herniation of intraarticular tissues, and this, in part, may allow forward displacement of the disc. About anterior displacement, I will talk you later today. The synovial membrane lining the capsule covers all the intraarticular surfaces except the pressure-bearing fibrocartilage. The forecapsular or synovial sulci situated at the posterior and anterior ends of the upper and lower compartments. These sulci change shape during translatory movements, which requires the synovial membrane to be flexible. Of attachment of this area. Temporomandibular ligaments. The ligamentous fascicles run obliquely downward and backward to be inserted on the back, behind and below the mandibular neck. Immediately medial to this layer, a narrow ligamentous band arises from the crest of the articular tubercle continuously, which attach with attachment of the outer portion at this side. This narrow inner or deep band runs horizontally back as a flap strap to the lateral pole of the condyle. An upper part of this band constitutes on to attach to the back of the disc, lateral to the condylar pole. Medial slippage of the condyle is prevented medially by the endoglenoid process and laterally by the temporomandibular ligament. The outer oblique band becomes taut in the protraction of the condyle, which accompanies the opening of the jaw, thereby limiting the inferior distraction of the condyle in forward gliding and rotational movements, while the inner horizontal band tightens in retraction of the head of the mandible, thereby limiting posterior movements of the condyle. Sphenomandibular ligament, ligamentum sphenomandibulare, arises from the angular spine of the sphenoid and pterygotympanic fissure, runs downward and outward, insert on the lingula of the mandible. Stylomandibular ligament, ligamentum stylomandibulare. This is a specialized dense local concentration of deep cervical fascia extending from the apex and being adjusted to the anterior aspect of the styloid process and the styloid ligament to the mandible's angle and posterior border. This ligament then extends forward as a broad fascial layer covering the inner surface of the medial pterygoid muscle. From processus styloideus to the back ridge of mandible. It is weak when the jaws are closed and slackens noticeably when the mouth is open because the angle of the mandible swings up and back while the condyle slides downward and forward. This ligament becomes tense only in extreme protrusive movements. Thus, it can be considered only as an accessory ligament of uncertain function. Very important function of TMJ and very important part of functioning TMJ, it is lubrication of the joint. The synovial fluid comes from two sources. First, from plasma by dialysis, and second, by secretion from type A and B synovicites with a volume of no more than 0.05 milliliters. However, contrast radiography studies have estimated that the upper compartment could hold approximately 1.2 milliliter of fluid without undue pressure being created, while the lower has a capacity of approximately 0.5 milliliter. What is this joint fluid? It is clear straw-colored viscous fluid. It diffuses out from the rich capillary network of the synovial membrane. This fluid contains hyaluronic acid, which is highly viscous. May also contain some free cells, mostly macrophages. And functions of this fluid. Of course, firstly, it is a lubricant for articulating surfaces. Second function, carrying nutrition to the avascular tissue of the joint. And last but not least, clear the tissue debris caused by normal wear and tear of the articulating surfaces. Next part, muscular component. The masticatory muscles surrounding the joint are groups of muscles that contract and relax in harmony so that the jaws function properly. When the muscles are relaxed and flexible and are not under stress, they work in harmony with the other parts of the temporomandibular joint complex. The muscles of mastication produce all the movements of the jaw. These muscles begin and are fixed on the cranium, extending between the cranium and the mandible on each side of the head to insert on the mandible. A very important part of joint system, the teeth and occlusion. The way the teeth fit together may affect the temporomandibular joint complex. A stable occlusion with good tooth contacts and interdigitation provides maximum support to the muscles and joint, while poor occlusion, bite relationship, may cause the muscles to malfunction and ultimately cause damage to the joint itself. Instability of the occlusion can increase the pressure on the joint, causing damage and degeneration. Colleagues, this figure called Postelt figure. I hope you know what does it mean. If you don't know, you can find this information yourself. Postelt figure. What kind of movements are present in TMJ? I told earlier that there are two types of movements, rotation and translation. Rotational or hinge movements in first 20-25 mm of mouth opening. But if we will open mouth more, then happens translation movement after that when the mouth is excessively opened. Hinge movements. The inferior portion of the joint between the head of the condyle and the lower surface of the disc to permit opening of the mandible. And translatory movements. Translation. In the superior part of the joint, the disc and the condyle traverse anteriorly along the inclines of the anterior tubercle to provide an anterior and inferior movements of the mandible.
The temporomandibular joint, the
Now, doctors,
TMJ,
let's
is the
summarize
joint between the lower
all
jawbone,
previously information
the mandible, and the
in
temporal
short
bone of
animation.
the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
And can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
And the small part of future information. There is shown normal correlation between different elements of TMJ. Condylar disc must be placed anterior superiorly from the top of condyle, not vertically, but in anterior superior direction. Now, about possible derangements of disc. The schematically shown anterior disc displacement. And what does it mean, anterior displacement? This displacement with a single click between position 2 and 3, a click is felt as the condyle moves across the posterior border into the intermediate zone of the disc. Normal condyle disc function occurs during the remaining opening and closing. Moreover, there can be medial displacement of articular disc or lateral displacement of the disc.
This is a normal temporomandibular
Now
joint.
I would like to show
The
you
disc is biconcave and it's located in a superior
legendary
position.
videos
The central thin part
about
of the
different
disc is
stages
consistently
of
lying in between
temporomandibular
the
joint.
condyle and tubercle.
First video, it is normal
During opening,
temporomandibular
there
joint.
is rotation in the lower compartment and more of translation in the upper compartment. And it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment.
Next video,
In this joint, the disc is
It is
anteriorly displaced
anterior disc
and
displacement
it's
with reduction.
reduced on opening with a click. In this joint, the disc is This joint demonstrates reciprocal clicking, which implies clicking during opening, followed by clicking during closing. This joint demonstrates reciprocal clicking, which implies clicking during opening. The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery. Corresponds very well to what has been seen on arthrograms and to reciprocal clicking is a clinical sign of anterior disc displacement with reduction. Reciprocal clicking is a clinical sign of anterior disc displacement with reduction.
Next video, anterior
The next
disc
joint demonstrates anterior
displacement
disc displacement
without
without reduction, which implies that the disc is consistently lying anterior to the condyle. The next joint demonstrates during all mandibular movements, the disc is lying anterior to the condyle and at maximum opening, the disc is folding downwards as seen here. The disc is lying anterior to the condyle and at maximum opening, the disc is folding downwards as seen. There is a considerable stretching in the posterior disc attachment at maximum opening. There is a considerable stretching in the posterior disc attachment at maximum opening. Disc.
Next video.
Disc. The next joint has a medial displacement of a disc. During opening, the disc is moving in lateral direction, and here the disc can be seen. Now it's displaced medially anteriorly again. And here it's replaced to a more normal position and displaced again. Clinically, it can be difficult to differentiate the pure anterior displacement from an anterior or anterior medial displacement. In this joint, the disc is biplanar. It's located on top of a condyle, but during opening, it's slightly displaced medially, and in association with this displacement, clicking was registered. The posterior attachment between the disc and capsule is considerably thinner than in a normal case. During closing, the disc is again replaced to a more correct position between the condyle and temporal component. The disc is lying in between the condyle and temporal component, but there is a type of reciprocal clicking caused by a mediolateral movement of a disc. In this joint, the disc is also located in a superior position. The disc is biconcave, with its posterior thick part located on top of the condyle in the closed mouth position, and posterior to the condyle at maximal opening. There is, however, a small perforation in the central part of the disc. During opening movement, there is rotation in the lower compartment and more translation in the upper compartment.
А якщо виключити телевізор?
There were no crepitation or clicking from this joint during movement. The location of a perforation to the central thin part of the disc is relatively unusual. In joints with disc displacement, it is our experience that perforations usually are located in the posterior attachment and not in the disc proper.
Так, а ну, знімайте. Я зрозумів.
When the condyle is distracted downwards from the temporal component, the perforation can be clearly seen.
Промисловим тільки з чуттями. Ну, потім буде спіралькою висіти.
Я зрозумів.
Якщо ви тут не заважаєте,
Та воно гарніше буде, якщо спіраль.
Of a posterior disc attachment.
Так.
The
Next
next
pathology.
joint demonstrates a large perforation of the disc. There is only a small piece of the disc remaining anterior to the condyle. This joint demonstrated crepitation and irregular movements.
So, colleagues, as you understood, it is native temporomandibular joints. It's not plastic, it's native human temporomandibular joints, and it is unique. It was unique video. Then, what symptoms of temporomandibular disorders we can observe in our patients? Not so much. Yeah? Let's begin from head. There can be headache on forehead, temples, migraine type headaches, sinus type, short in pain up back of head, hair and or scalp painful to touch. What does it mean, the different kinds of pain? I would like to show you schematically forehead pain, migraine tape, sinus tape, temples, scalp painful and back of head. They are schematically shown different kinds of headaches. Next area, eyes. Patient can feel pain behind eyes, bloodshot eyes may bulge out and sensitive to sunlight. Mouth. discomfort, limited opening of mouth, inability to open smoothly, jaw deviates to one side when opening, locks shut or open, can't find bite. Teeth, clenching, grinding at night. They are signs of a night bruxism, looseness and soreness of back. Throat, swallowing difficulties, laryngitis, sore throat with no infection, voice irregularities or changes, frequent coughing or constant cleaning of throat, feeling of foreign objects in throat constantly. Neck problems, lack of mobility, stiffness, neck pain, tight, sore muscles, shoulder arches, edges and back aches, arm and finger numbness and or pain. Jaw problems, clicking, popping jaw joints, grating sounds, pain in cheek muscles, uncontrollable jaw and or tongue movements. Ear problems, hissing, buzzing or ringing, decreased hearing, ear pain, ear ache, no infection, clogged, itchy ears, vertigo, dizziness. As can you see, doctors, they're not so difficult to differentiate temporomandibular disorder with some another diseases, yeah? At the end, I would like to recommend you a few textbooks. If you would like to learn this problem deeper, you can use these books or these articles. I picked free access articles and more popular topics of them.
Oh my god, Niall. Oh my god, Niall!
Colleagues, do you know
Niall!
about our today's
Oh.
situation in Ukraine? And I would like to advise you, keep calm and just smile.
Oh my god, Niall. Oh my god, Niall! Niall!
Thank you for your attention. Please, maybe do you have some questions?